Okay, so today we'll be dealing with the topic delirium. Okay, slide. Can you please share the slide? So, delirium is something which you might have seen in your medical field. Okay, in your when you were in doing your nursing or doing your practice. But only thing is, you might not have understood what delirium is. So today we learn in detail about delirium, the clinical features, how do we like what is it and how does it present, how we manage it, and all those things. Okay, so let's begin our class. So, as a definition, it is defined as a global cerebral dysfunction. Okay, something related to the brain. There is a global cerebral dysfunction which is characterized by a concurrent disturbance in certain things. What are the things? Alertness, awareness, attention, thinking, perception, memory, psychomotor behavior, mood, and sleep based cycle. Okay, we'll discuss everything in detail. Just you know about the definition, something happening to our global, our brain, there is a failure, there is acute brain failure, resulting in some of the aspects controlled by brain, that is alertness, awareness, all those things are controlled by brain. So all of a sudden, the patient will have a acute confusion, something related to a confusion, and they'll show it as a difference in the all those aspects. Okay, and also you have to know that this delirium is acute in onset. It happens very suddenly. Okay, and also it will be reversible. It's very important. We'll discuss everything in detail. Just you know about the definition. It's a reversible process. Delirium is a reversible process. Next slide. So, in short, it is a state of acute confusion or it's a state of happening due to a acute brain failure due to different causes. Okay, next slide. So, about the burden of delirium, how common is delirium? You can see that nearly 3% to 42% of hospitalized patients have delirium. Is that a very small number? No, 42% of the hospitalized patient. It means nearly 40% out of there are a lot of patients with delirium. So, we need to know about this. Okay, and also 85 percentage of patients in end of life. Those patients whose disease progress and when they end near their life or when during the end of life, the prevalence of delirium, patient having delirium is very common. So we need to know about this. Okay, now coming to hospitalized patient. Next slide. The incidence in a hospital setup, where do you find patients with delirium? Most of the time, it will be in an ICU setting. Okay, not only in the ICU setting, patients in hospital who are admitted in hospital for 4 to 5 days or more than like 3 to 4 days, they can develop delirium. But in ICU, see the percentage, it is nearly 22.6 to 68%. 68% is a very high number. Nearly, in short, we can tell you that nearly 6 out of 10 patients in an ICU setting can have delirium. Okay, that is not a short number, that is not a small number, that is very significant. Okay, now in our mind, when we think about delirium, we'll only know about those patients who are becoming very angry, who are pulling out the Riles tube. Is that the only type of delirium? No, there are certain types. So there are three types. Okay, hyperactive delirium, hypoactive delirium. No, not three types, two types. Hypoactive delirium, hyperactive delirium, and there is a mixed type. Okay, so see the percentage. Hyperactive delirium is only 1.6%, and hypoactive delirium is common 43%. This is all these are record based on studies. They are telling based on studies, different studies conducted in different ICU setting. Okay, these are rough ideas, but to show that this is not very rare. This is they are telling that this is very common. You have to know about this. So, what is hyperactive delirium? Next slide. Hyperactive delirium is when the patient become agitated, the patient become restless, remove catheters, tubes, biting you, hitting you. You can see patients, right? Remember patients in ICU shouting at you. mostly the nurses will be they'll be suffering all these aggressive behaviors, right? So remember that that could be because of delirium, okay? And not only this agitated patients, you can see some of the patients when you ask, sir, what's your name? And the patient will be like, no response. They'll be lethargic. They'll be like sometimes some people will be doing something around the bed sheet, making some doing something like this. That is known as hypoactive delirium. Those patients will not become aggressive, like they'll not pull out the tubes, but they'll be in a different world. They'll not give a proper response. They'll not give you proper answers. They'll be in a flat effect and they'll be very tired. So you should know that that is hypoactive delirium. So there is not only hyperactive, that's also hyperactive. And there is a mixed type. Some can present with, sometimes they'll be very quiet and sometimes they can become aggressive. So what I was trying to tell was in ICU, it is very common. This type of delirium, not only in the ICU, but in the wards also, you can see this kinds of patient. Those patients who are admitted or hospitalized for a very long period, they can develop delirium. Okay, next slide. So now you have to know about the clinical features. So we learned about the definition. Learn about the incidence, how common it is. Now we are going to know about the clinical features. Then only we can pick it up. Okay, how do these present? How do these patients present? We can learn that. Okay. So, prodromal symptoms, the initial symptoms. So, you can see that none of the patients will become like agitated very fast. Initially, they'll show some small features. That is known as a prodromal symptoms. For example, they'll become restless. They'll become a little anxious. They'll be telling them the facial expression. You can make it out. They'll be anxious. They'll be some kind of irritable. They'll not properly answer you. Like some kind of irritability will be there. Sleep disturbance, patient will not sleep at night. So or sometimes a caregiver can come and tell you you are in another setup, and a caregiver and coming and tell you the patient, see, my father is very restless since last few days. He's very anxious. He's irritable. He's having sleep disturbance. So you should be able to pick it up. You should be able to pick up that is these are the prodromal. It can be the patient can develop a delirium in the future. So you have to know about this. Now, another second clinical feature is fluctuating course. What is that? What is that? That means the caregiver, I can give an example. The patient's caregiver will be telling clearly that, ma'am, my father, he's okay in the morning, and in the afternoon, he speaks something, some irrelevant speech is there, and evening, he's okay. He's having some irrelevant speech in between. Otherwise, he's okay. This is important. This is known as fluctuating ghost. The patient will show a normal behavior at some time, and sometime they'll show this aggressive behavior. So the nature of delirium itself is fluctuating. The patient typically they will present like this. They will tell like this. Sometimes he's normal, but sometimes he's telling some irrelevant things. Okay. So that is that you have to. This is a feature of delirium. You have to keep it in mind. Next one is attention deficit. This you can notice when you go for rounds. Hmm? When you try to talk with the patient, he'll not give a eye contact. He'll be looking at somewhere else. And when you keep on talking with them, you can understand that after 2 3 seconds or 10 seconds, patient will not be answering your questions. He's not able to concentrate. So from there, you have to pick it up. Oh, see, there is some abnormality in him. I have to find it. So the attention deficit is also a hallmark. Okay. So reduced attention span, shift attention to a new stimuli appropriately. They'll not be able to switch, or they will like want to, they'll not like concentrate. They'll not be able to concentrate. Okay. Memory impairment, poor registration and retention of new material. If you have seen the patient for a very long period, and if you ask, who am I? Do you know who am I? Then he'll be telling sometimes no. Okay, what did you have in the morning? Do you remember what you had in the morning for breakfast? And they'll be telling, yeah, I don't remember. So poor memory, like memory impairment is also very important. They can present like this. So attention deficit is also a hallmark. Okay. The patient might have a disorganized thinking. It is different from the normal thinking. So they'll tell something else. So that also you have to keep in mind. Irrelevant speech. Patient will be talking about like very irrelevant things. They might talk about some bank or I don't know, it can be anything. Okay. So all these things you have to know. Next slide. Perceptual distortion, misidentification. This is very common. Okay. Illusion and hallucination. Hope you all know that. So the patient can get hallucination. See, there is a snake running over there. See, somebody is looking from outside. Somebody is trying to kill me. They will tell all those things. Illusion. They will consider one rope lying there. So see, there is a snake. So all these kind of perceptual distortion can happen. Okay, and inability to recognize people. I told you the doctor who was seeing them daily. They'll not recognize. That's okay. Patients, this thing. Sometimes what happens is they'll forget their primary caregiver. Sometimes the wife will be their primary caregiver. Or I had to come across such a situation where a patient whose wife was a primary caregiver. And one day this man told, see, this is my something, my friend or something he told. So the wife got she got totally devastated. She was telling, I took care of him for a very long time, but now see, he is not able to remember at least me. So we had to tell her, see, Amma, this is something they call delirium. Patient is having perceptual distortion. He might not understand. He has memory impairment, all those things. So so we need to know that. Okay, we need to know to tell this to them. So then increased or decreased psychomotor activity that we know the patient tried to escape. It's not because they want to leave the hospital. Maybe because of their thought, the attempt to escape. Psychomotor activity means the strength, everything will increase. They'll try to escape, remove the medical devices. A patient pulling out rice tube. Don't scold them. Okay, they are not doing it purposely. Not everyone, but at least most of the people having delirium, they are not doing all these things purposely. Don't scold them. Don't shout at them. Okay, this might be because of this delirium. And disturbed sleep-wake cycle. Sometimes a patient disturbed sleep-wake cycle means patient may have a sleep reversal. They'll get up in the night and sleeps during the daytime. This is a very common presentation. People will tell like that, or they'll not have sleep in the night. And sometimes they'll be in this all these kinds of increased psychomotor. Decrease means they can be completely lethargic. Okay, next slide. A mood. The mood can be like sometimes different people will be having different moods. Sometimes some people will be showing anger, some people will be showing sadness, some may be very happy also. So everything in excess is a problem. Okay, even if they are happy and if there is excessive happiness without any reason, that can also be a problem. Agitation, very aggressive behavior. Some can go into like even fight, and they can bite, they can hit, they get good energy during this time, and they can hit you also. So be careful. Okay, you have to know about this. Next slide. So I've told all these things. So during your rounds, when you assess your patient, okay, you should always, this is the importance of asking whether and writing. You always write in your notes, okay, you write the patient is conscious and oriented. So you have to ask the patient, you have to regularly ask the patient, see, in a nice way, not like every day I've written name, place, person, and time. Not like every day going, what is your name? Not like that. You have to ask in that some other way. Okay, you have to find some kind of way. And how are you? How do you feel today? Sometimes they'll not be able to tell that. You can easily, and where are you now? You ask, where are you now? I don't know. I don't know whether I'm in hospital or home. From there, you can pick. A normal person can identify their place and surrounding, but this person will not be able to identify their surroundings. So, in your rounds, have a check on the conscious and orientation level. That is the easiest thing you can ask in a very friendly way. Different. What time is it? Do you know the time? The patient will not be knowing about the time. A disoriented person will not be knowing about the time or place where they're at. So these are the simple things you can ask, and this is the importance of writing the conscious and orientation level. Okay, next slide. So some of the essentials for the diagnosis. We have already discussed this in the clinical features. So there is a change in short. There is first one is a change in cognition. The patient will have disorientation, language disorder. Sometimes they'll not be able to talk properly. They'll be talking different things. Memory deficit, unable to recall things. Perceptual disorder, disturbance, and the one thing is it should not be accounted by dementia. That we'll discuss. How can we differentiate delirium from dementia? In the end, we'll come to that. Okay. But because all these things are very common with delirium also, but we'll discuss how we differs with delirium. Okay. So this is a one essential thing to diagnose. Second one is developmental cause. It is an acute or subacute. Okay. Means it has like set in within a short period of time, maybe hours, maybe days. Oh, so it is a very short in onset, and with fluctuation during the course of the day. All these things are important. Okay. Disturbance in sleep and wake cycle, often worsening of symptoms at night. This is very common because when we take a night duty, we know that all these patients will have problems at night. This is not a sundowning. This is because sometimes during night time, the sound reduces, light reduces. All these things can increase our anxiety and in turn precipitate delirium. Okay, so this is very, you have to know that most of the time, the night duty staff will be telling, oh, the patient was delirious, but the morning staff will be telling, oh, he's okay in the morning. So it is there. Okay, delirium fluctuates during the course of the day. Okay, next slide. So the third thing is disturbance in attention, reduce ability to direct, focus, sustain, and shift attention. And evidence from the history that disturbance is caused by direct physiological consequence of general medical condition. And you can know that the patient will be having certain diseases, and we'll be discussing about the cause, and that could also be a criteria for this thing. Okay, next slide. So you have to learn about the causes of delirium. What and all cause delirium? First one is drug. Okay. Can somebody tell me few drugs which cause delirium? Very common drug, at least one. First, you should tell that. Should be able to tell which drug cause delirium. Morphine? Yeah, very good. Morphine is the first thing you should come that should come into your mind. Mm. Benzodiazepines, all these can precipitate delirium. Okay. Morphine, all the opioids, it's very common. Sometimes a patient can cause delirium. So whenever you prescribe morphine, during the review visits, you have to ask the caregiver history or clinical features of delirium. The patient having irrelevant speech or something like that, you have to keep an eye on this. It's because this is very common. Sometimes morphine can cause delirium. Okay. And the mnemonic is delirium itself. Okay. For the causes of delirium, the mnemonic is delirium. Okay. This is very easy, like made easy to for you to understand. So E means eye and ears. Eye and ear means sometimes this patient, those with reduced vision and reduced hearing, these patients can have delirium. When the eyesight decreases and when the hearing ability decreases, the patients can get. They'll be in a different world. They'll not be seeing anything, and they'll not be hearing anything. And when they could go in that cause along with some other diseases, they can develop delirium. Okay. Next one is low oxygen in cell, like myocardial infarction. When during the myocardial infarction, stroke, pulmonary embolism, all these kind of diseases, life-threatening diseases, the patient will be in a very sick condition and they can also develop delirium. Next one is infection. Infection is very common. Patient, you remember patients who are in ICU. Okay, those with a severe infection. When the patient is in a condition with a severe infection, they can get delirium. That is the reason why those non-cancer patients, those who are in ICU, they can get delirium. Okay, retention. This is very important. Okay, retention of both stool and urine. Okay, those patients who have, it's not a cystocerebral syndrome. I'm not explaining much about it. Sometimes this is very common. Okay, I can give an example. A patient coming to your casualty. Okay, your palliative patient coming to casualty, and his wife is telling doctor, see, he's talking some irrelevant speech. I don't know whether he has gone mad. I don't know. Since yesterday he is telling some other things and all. Then we have to ask, after taking the long history, we have to ask two questions. Did he pass urine? When did he pass urine? And then she'll tell, oh doctor, since yesterday morning he has not passed urine. Okay. And or else, so another scenario, the patient has not passed stool since last 5 days. There you have to catch. Okay. Retention of urine and stools. Okay. Urinary retention can precipitate delirium. That can, after relieving the urine, a patient can, the delirium will go, the patient will become normal. Okay, so you have to counsel the bystander that this might be the cause of his this problem, so we have to correct it. Constipation, same way, we have to think about it. It is very, very common. Those patients who are taking opioids, those patients who are having low, very oral, very poor oral intake, they'll have constipation and they will present with delirium. Okay, so first you have to correct this problem. So for that, you have to know that retention of both of this urine and stool can cause delirium. Okay. Ictal, increased level of bilirubin, increased level of bilirubin post-ictal states, and they post seizure also. Sorry, post seizure state, they can have delirium. They'll be in a different. They'll be having delirium. Okay. Uncontrolled pain. This is also very important. I'll give you an example. A patient having severe pain, okay, for a very long duration, nearly for like 2 weeks. Patient was having severe pain. He was on morphine, and suddenly, for like 2 to 3 days, he started having irrelevant speech, and he's not coming. He's totally detached. He's telling having irrelevant things, and now his wife will be telling doctor he was having pain, but he's since 2 3 days he's not saying anything about pain. He's telling about something else. This is because the patient might have delirium because of pain. Uncontrolled pain can precipitate delirium. Okay. Now metabolic. Metabolic means our electrolytes, metabolic changes. Sodium, a change in sodium. You know, no? Sodium and potassium, hyponatremia. All these can precipitate delirium. Okay, next one, next slide. Next slide. So, the pathophysiology, it's actually not known. It's poorly understood. Okay, different studies have made, and they have come into a small conclusion that delirium might be because of the deficiency of acetylcholine and excessive of dopamine. That's why increase in dopamine, the patient can get restless. So, the real pathology is actually not known. Next slide. So, coming to the risk factors of delirium. Okay. So, coming to the risk factors of delirium. So, there are certain unmodifiable things which you cannot do anything, and there are some modifiable risks. There we have to intervene. So, first we learn what are the unmodifiable things we cannot change. Okay, extremes of age. So, these are the conditions. I'm talking about the conditions that can precipitate and cause delirium. Okay, these things we cannot change, but these all can be the cause. Extremes of age, okay, a frail old patient can develop this thing delirium. Dementia, a patient having pre-existing dementia, old a lady who is 83-year-old who is having dementia can precipitate with the delirium. Sometimes infection or sometimes a constipation. All these can precipitate a delirium very fast. So all these things we cannot do anything. Dementia has no have a don't have a proper treatment, right? It's a advancing disease. History of hypertension, alcohol or tobacco use, history of depression, high severity of illness, reduced physical activity, lack of daylight in ICU. All these things are there. In all these conditions, it is easier for the patient to develop delirium. Okay, next slide. And potentially modifiable or preventable. This is what I told, sensory deprivation. Sometimes I'll give you an example. A patient who is not very old, like a 58-year-old patient, not 58, 60, 60, above 60 patient who is having hearing loss. He was using a hearing aid. Okay, when he is admitted, he got admitted in the ICU, and his family members have taken away the hearing aid with them. Okay, he's inside the ICU, he's not having his hearing aid. So he's not able to hear. After 2, 3 days in ICU, he'll feel like something and all is happening. I don't know what is happening. So there is the thing is he has a hearing aid which he was able to hear. Somebody has removed it. Now he is not able to hear it. And sensory deprivation, that is affecting his sensory stimulation, that can precipitate this thing. So what you can do? A patient who was using a hearing aid in ICU, if possible, you can give them. If the patient is developing delirium, to get him back to normal, you can give his hearing aid. Or if he is using a specs, he is not able to see anything. He's lying somewhere there, can't see anything. Something and all is happening. They can become anxious, right? So that is the importance of knowing the sensory deprivations. You can, these things are modifiable. You can do, you can intervene. Now, like anemia, infection, acidosis, metabolic correction, fever, in all these situations, you can try to correct. You can try to correct the anemia, infection, the metabolic correction. You can do the sodium correction. So all these things, yeah, this thing. Lack of visitors. We have so many patients here. Like sometimes there'll not be anyone to any relatives. They don't have anyone to talk, and they'll be lying like plain, something happening, don't know. They are also prone. You can talk with them. So it's to such patients, you can talk, you can comfort them, you can ask them, you can have a small chit chat, you can ask, you can talk with them, you can have a friendly this thing with them. Okay. Now, benzodiazepines. Benzodiazepines is very important. This is because sometimes a patient having delirium. Okay, we'll talk about the management later, but just for you all to know, a patient having delirium and you are trying to infuse a benzodiazepine like midazolam and chlorazepam without identifying the problem, what is the cause of delirium, without thinking about anything, you are giving a midazolam. Actually, sometimes it can worsen. Okay, benzodiazepines. We have to treat the cause of delirium, and then we have to we use the midazolam for controlling the aggressive behavior. But for that, you have to first you have to take away the cause of the delirium if possible. Otherwise, simply giving midas, give them lorazepam, give them midazepam, all these things can worsen delirium. You have to know that. So the actual treatment is different. Midazolam is there, it helps, but it is in a different way. It is not the primary drug of choice for delirium. Okay, so you have to know this. Okay, if you see someone who is having delirium and they are giving only midazolam and day by day he is becoming more delirious, you should be able to tell them, see, benzodiazepines can worsen delirium. Okay, without proper treatment for delirium you can't give benzodiazepine, it can worsen the delirium. Okay, now immobility, the patient is lying down. Consider yourself when you are immobile for a very long period, you can develop, you may become agitated, you may become restless. So consider that these are all you try to we learn about this like immobility, how to mobilize them, we'll try. So all these things should come to your mind. Okay, next slide. So precipitating factors for delirium: change in environment, to hospital or to ICU. This is very important, as we told. Why in the hospital we have so many patients having delirium? This is because of the change in environment. This is the reason why we always try to promote patients to be at their house, to be very comfortable. Okay, for at least most of them, their home will be home sweet home, right? They'll be very comfortable at their house. So each time when you visit them and tell, no, no, you should not, you are having so many problems, let's go to hospital and let's get admitted there. No, that's not correct. We have to try to maximum, we have to try to keep the patients in their most comfortable area where there is hope. Okay, because this is the reason. When you change their environment, old age people, think about all old age people, most of the time it will be old age people who are getting admitted to the hospital, who gets delirium very fast. They'll become agitated very fast, they'll pull out their ice tube, their kids will be shouting at them, all the nurses and all the doctors will be shouting at them. You should know, okay, this is a basic thing. So a change in environment can cause this thing. So you have some patients, I have also seen some patients who are admitted for a very long period in hospital, whose family members will not be like, they'll be will having so much fear that, oh, we take her home, and if something like pain increases, what will we do? And they'll keep on prolonging the admission, and the patient will get delirium. So what you have to tell is, see, the patient is having this kind of problem, is because he's staying for a very long time in hospital. He might become better if you take them back to home, if you give them a change in environment. So this is a very good point to tell them. Okay, the patient, there is a change in environment. The change in environment to home itself can bring them back to normal. Okay, so these are the precipitating factors. Now, an unfamiliar excessive stimuli. Sometimes those patients who are abandoned patients who are excessive cold or hot in IC also, they feel very cold. If the patient is having very cold and they are not able to tolerate, all these things can make them discomfort, like make them uh, very discomfort, and that can in turn precipitate delirium. Wet sheet, if they have urinated and there is nobody to look after when they are lying in the bed for a very long time, this can also precipitate. And the general deterioration of condition. So sometimes you might get like family members telling, "Oh, doctor, when we came, the patient was okay, but in your hospital, he has become like this." So it is very important to explain them all these causes, maybe the change in environment, and also this deterioration of the condition. Most of the time, palliative patients whose diseases will be advancing, that can also precipitate, can also become a precipitating factor for delirium. So you will have to explain those things to the caregiver. Okay, next. So, other thing about the cancer itself, primary or secondary brain tumor, something already there is an acute confusion or acute brain failure due to different causes in the brain, causing all these kind of problems, alertness and all. So, when you have a malignancy, think about it. When you have an extra malignancy, a tumor in your brain, that can in turn cause delirium. Okay, so patients with metastasis to brain or brain malignancies, they can also present with delirium. Okay, and pro-inflammatory cytokines that we have already discussed, infection, paraneoplastic syndrome, biochemical disturbance like electrolyte imbalance. All these can cause precipitate delirium. Okay, okay, next slide. And what, like we tell, uncontrolled pain, you have to know, right? The patient can have a pain, severe pain for a long period, fecal impaction, urinary retention. This should be in your mind. Okay, you should not this should go into your brain. These are the very common things. When a patient comes to OP, you have to, and complaining about delirium, all these things should run in your brain. So that could be because of pain, could be because of fecal impaction, could be because of retention, infection. Then you try to rule out. Okay. For that, you have to know what are the causes. Okay. Next slide. Alcohol, nicotine, psychotropics, in the withdrawal state, all these can, all these conditions, although you can imagine, right? The patient can become aggressive in a withdrawal state. Okay. Next slide. hepatic, renal, and respiratory impairment. The level of in hepatic impairment, the level of bilirubin could increase, and it can affect the brain. There is a metabolic this thing, and it can precipitate as a delirium. Renal impairment, increased level of urea creatinine, that can in turn cause delirium. Next slide. So there are different assessment tools. I'm not going into detail about this. Confusion assessment method for in different ICU settings, they have different this assessment sheet. Different this thing follow like different hospital follow different scores and all. What we can do is clinically we can find it. That is the easiest method. Like knowing the different criteria and knowing the different cause we'll be able to pick this thing more. Okay, I'm not going into this assessment tool. Just know about that there are so many assessment tools for this for assessing delirium in ICUs and not ICU settings. Next slide. Now coming to the mimickers of delirium. Okay. See, there are different things like delirium, dementia, depression, and psychosis. This should be in your mind. How delirium is different from psychosis, how delirium is different from depression, and in each thing. See, the first thing is acute change in the mental status. Like we said, delirium, difference between delirium and dementia is very important because most of the time we get confused with both of it. Okay, so acute change in the mental status. That's something which happens very suddenly. But what is dementia? It happens in a very long period. Patient shows this thing in not it is not just in few hours or days. It will take a very long time. Patient having memory impairment or becoming a lethargic and all these things. It will be very slow process. Dementia. Okay. Unlike delirium, which is short. This is a one of the best picking difference. Okay. Then inattention, it is common in both altered consciousness. Most of the time, a patient with delirium will be drowsy. But a patient with a dementia, they'll not be like every time they'll not be drowsy. Nothing like excessive drowsiness will be there. But patients with delirium, the sleep wake cycle will be disturbed, and there most of the time they'll be sleeping. All those kinds of problems will be there. So there also you can differentiate. Okay, disorganized thinking, altered psychomotor activity, chronic duration. All these things are both both of them have like a plus and minus. But these two things are the most particular ways, most particular differences. That is a acute change in the mental status and the third point, the altered consciousness. Just the other things you can have a look, depression and psychosis. There are a few differences. The main thing about our delirium is it is acute in onset, it is fluctuating, there is a change in the mental status, and there is a altered consciousness, and all those things. Okay, next one. So coming to the management, correct the correctable, non-pharmacological and pharmacological methods. Correct the correctable means if you have an anemia, if you found an infection, treat whatever things are like treatable. Okay. Now the non-pharmacological methods. Next slide. This is very important. Okay, this we are coming to the way now. Now we have understood what is delirium, like how to pick it, who is having, what is the cause and all. Now it is action, coming into action. There are so many things you can do. Okay, it's not only giving a drug. The most common drug we give in delirium is haloperidol. Don't jump into this type of drugs. You have to go for this non-pharmacological management. Optimize. So coming to each point and point, like optimize sleep wake pattern. So we'll discuss in detail about each point. Okay, next slide. Next slide, please. Okay. Optimize sleep wake pattern. Okay. Most of the time, the patient's bystander will be telling, see, doctor, he sleeps at daytime and wakes up at night. First thing you have to correct, you have to try to correct it. Make the patient try to sleep at night and wake up in the morning. Ask them to, in the daytime, ask them not to sleep. Try to listen to some music, read newspaper, or do something else. And don't make them sleep in the daytime. And at night time, give them a good space to sleep. In the ICU also what you can do, if possible, if you can lower the light. There are some ICUs they can where they lower the lights at night and noise also. At night, the staff will be like so making so many noise. We have to talk, but still try to. If you have such a patient in your ward who is having a problem, you keep this in mind. Okay, don't make too much noise at night and try to lower the lights and make them tell the caregiver try to engage him in some activities at morning. Okay, and don't encourage him to sleep in the night, and you can give some sleeping pills if you want at night so that his sleep cycle can reverse. Mhm. Okay, next slide. Patient orientation. Okay. Orient the patient. When you talk to the patient, he'll be telling some other big things. Okay. Irrelevant things. Don't make joke. Don't shout at them. Don't tell him what are you saying is that is wrong. Don't do like that. Repeatedly try to orient the patient. See, you are here. You are in the hospital. Do you know that? Yeah, we all are with you. You can tell like that. Huh? We are in the hospital. We all are here. Like this, I am this thing, repeatedly oiling the patient. Maybe the next day he'll forget it, but oh, that's okay. Okay. Explain where are they, who are you, what are you doing, and you can write it. You can then also you can keep a visible clock where they are lying down. You can keep a clock in front of them so that they'll be knowing about the time. This is very important. In our wards, in our hospital wards, we have nearly 4 or 5 clocks in the wards. That is for every patient to see the time. Okay, for everyone to see the time and to know the day and night. Maybe they'll not be able to, like, you have to tell them if it is 4 o'clock in the morning or 5 o'clock in the morning, but they should know about it. So this is a this is a thing you can do about orientation. Repeatedly orient the patient. So, say softly. Ask the caregiver also to do like that. Okay, don't shout at them, don't scold them, don't make joke. I have seen people making jokes. Okay, we don't know about the condition. That's why we make jokes and all. So try tell them like, see, he's having such and such problems. That is because of this his disease, and you have to correct it in a better way. Okay, next one. Communication, giving eyeglasses, hearing aids. This is very important. Okay, don't forget it. If you have a patient who is not using like glasses or not using hearing aid in an ICU and all, ask the permission of the doctor and you can get it for them. Dentures. They sometimes there will be some old grannies telling, "Oh, I'm not able. Where is my denture? I'm very uncomfortable with it." If they're telling so, you can give. Okay, next one. Encourage mobility, mobilize as much as possible. Those patients who are bedbound, you can take them out. Evening, we have a practice in our IP. We take those patients who are able to walk a little or use a wheelchair. We take them out. We take them, sit them, make them sit at the like in our veranda for some time. So they'll have a little more orientation. They'll like mobilizing is very effective. Okay, sit out of the bed for meal if possible. Don't make them sleep all the time. Ask them to sit in the chair and eat if possible. Okay. Avoid using physical restraint. This is very common. This we can't do much about it. Sometimes we'll see, in the ICUs and all, we restrain the patient. It's actually very sad to see. For not pulling out the rice tube. We advise not to restrain the patient unless if he's so violent. Okay, have a look on him, try to console him, try to reassure, reorient, and try your maximum not to restrain the patient. Only if it is like unavoidable, do it. Okay, minimize the use of catheters. The problem with these catheters are they'll make you like bedbound. Most of the patient after giving a catheterization, before that they'll be at least going to the bathroom. Okay, they'll walk and go to the bathroom. But after if you give a catheter, they'll become bedbound. So when you prescribe a catheter, always think about it. Minimize the use of catheter. If the patient is passing urine, is having a good control and not, don't use unnecessarily. Okay. So mobilize as much as possible. If the patient is telling us, see, I am having severe pain, I can't move, then we can't do anything. But if he's telling, yeah, I want to move a little bit out, I can sit in the wheelchair, then take him out, take him near a window, show him outside. Okay, next. Monitor bowel and bladder function. That is very important. Like you have to assess about the urinary retention, constipation, fecal impaction. Very important. Very, very important. Very important. Okay. So constipation you have to rule out. These two things are very common in an acute setting. Okay, most of the time they will be coming like, doctor, we don't know what happened since yesterday he's like this. Then you have to rule out these things. Next. Provide support and education. Involve the family, educate them, ask them to reassure the patient in a calm voice. Don't shout. I have told already. Don't shout. Don't shout. Okay. Don't like scold them. Sometimes they'll be. I already told you. No, this is not that. Not like that. Calm in a calm voice. Huh? Make them also involved in reorienting the patient. Okay. Next. Now coming, you have all done most of the times. After doing all these things, the patient will improve. Okay, this non-pharmacological method is a very good thing. It's not like we are just trying it. Most of the time, after doing the non-pharmacological method itself, the patient will improve. But if your patient is not improving with it, he's becoming violent, he's becoming aggressive, then you can go for the pharmacological management. Next slide. So, for situation, the patient is distressed, non-pharmacological methods have failed, patient is a risk to themselves or others. The patient is going to hit you, okay? Then you can't wait for the pharmacological methods and stand. Right? Then you have to go for this thing. You have to use your senses and common sense and do accordingly. Okay, next. So, the antipsychotics. Patients with delirium, the drug of choice is antipsychotics like haloperidol. How much we give? We can give the usual doses we can give 1.5 milligrams or 1 to 2 milligrams can give every fourth hourly. It's not very common. What we usually do is we give 1.5 milligrams at night. Okay, nearly at 7 p.m. You can start it as a HS dose. Or if the patient is coming to your OP with a acute problem, you can give a stat dose of 1.5 milligrams IV. The patient is in an OP setting with a very moderate level of delirium, then you can go for tablet. It is available as tablet. Haloperidol is available as tablet. IV, you can give it as IV, you can give it as sub-Q, all the routes. How? You can, which dose you'll give? You can give it up to 1 to 2 milligram each dose. Okay. So in our hospital, what we do is we give we have tablets of 1.5 milligram. Also, as when we give IV also, we give 1.5 milligram IV as either as HS. If the patient is in a regularized dose, we can give HS. The patient is admitted here. We give haloperidol in the evening because most of the time this delirium will increase at night. So we'll give regularly for nearly 3 to 5 days or for 1 week we can give and we can see look for the change and also you have to know about the maximum dose of antipsychotic that is can up to 15 milligram in 24 15 to 20 milligrams we can give the can repeat the haloperidol. Okay, if a patient comes to you in your OP with distress and you give 1.5 milligram nearly after 20 minutes you can repeat 1.5 and every fourth hourly also you can give. Okay, if the patient is having such an agitation, like very agitated, you can give it fourth hourly. But you have to keep it in mind. There should be a maximum dose of really 15 to 20 milligrams. Okay, watch for extrapyramidal symptoms. Higher doses of haloperidol can in turn causes extrapyramidal symptoms. Okay, it can increase agitation, restlessness, and all. So this slide should be in your mind. So haloperidol is a drug of choice for delirium. When the patient is having a hyperactive, more particularly when the patient is having a hyperactive delirium. Okay, next one. Other drugs are now benzodiazepines. So the primary drug should be antipsychotic. The patient is having all kind of psychotic problems. First thing is haloperidol and benzodiazepine as a supporting agent. Okay, always the dose of Haloperidol should be little higher. Okay, benzodiazepine should be low. Like I told earlier, benzodiazepine can worsen. Sometimes can worsen the delirium. So, but as a supporting, you can give after giving haloperidol. If the patient is like not settling, you can give midazolam, either midazolam 1.2, 1 to 2 milligram every 2 hours, or of a maximum dose of 30 milligrams, and lorazepam 1 milligram every 2 hours. All these things are so the benzodiazepine is only supporting agent. You can use it. Nothing like there you don't fearing that it will worsen delirium. You can't use nothing like that. You can use. Okay. First you use haloperidol. Huh? Like you can repeat you can give one haloperidol and you can repeat it. Then you can give a benzodiazepine. Okay, clear? Next. So, coming to the conclusion, always correct the correctable. Like we always say, go for non-pharmacological management as far as possible. Okay, here the non-pharmacological method is more important than the pharmacological method. Okay, so don't forget about this is very important. A multidisciplinary approach may be needed. The whole team has to involve, the whole family have to involve, always communicate and take the caregivers along and identify the hypoactive delirium at weight. In ICU, most of the time the hypoactive delirium will be ignored. Such kind of patient we have to identify. We need to know that this patient is having this kind of problem. That's why he's behaving like this. So all these things you have to keep it in mind. Okay. Next slide. Thank you. So this is the end of our class. So there are a lot of things in delirium. It's a little difficult thing to manage. Okay. Any doubts? Can ask doubts.
If you have any doubts or queries on the sessions, you can either unmute yourself or you can put the messages in the chat box.
No doubts? Let's go to the presentation. We'll continue with the presentation.
Yes, ma'am. If they have
Okay.
any, they don't have any doubt, we can move on to the case presentation.
Yeah, okay. Let's go.
So today our case presenter will be Kumari R. Welcome, ma'am, for presenting the case. Ma'am, you can start presenting.
Yes, ma'am. Good evening, ma'am. Today, my case presentation regarding delirium. My patient age is 72 years, male, and he is a retired teacher and widower, ma'am. Regarding presenting complaints, it was confusion and disorientation for past 24 hours. And my regarding history of illness, John was admitted with pneumonia 2 days ago and started on antibiotics and oxygen therapy over the past 24 hours. He has become increasingly confused, agitated, disoriented, especially at night. And past medical history is a known case of diabetes and hypertensive and mild cognitive impairment. On examination, vitals, ma'am, temperature 99.6 degree Fahrenheit, heart rate 90, and blood pressure 130 by 80 mmHg, respiratory rate 20 breaths per minute, oxygen saturation 96% and room air, and general appearance anxious, disoriented, and respiratory system crackles here in both lungs on lung basis. Neurological system, he was alert but confused, oriented to person. Sir, previous slide, sir. Psychosocial aspects is delirium causes confusion, disorientation, hallucinations, agitation, mood swings, anxiety, and disturbed sleep, profoundly impacting his cognitive and emotional state. and exacerbating his overall mental confusion. Medications includes antibiotics for pneumonia, injection levoflox 750 mg OD, IV fluids for hydration, and potentially low-dose antipsychotics like haloperidol for severe agitation, all while minimizing sedatives and deliriogenic drugs. Main concern regarding my patient, the main concern for him is managing his delirium to prevent further cognitive decline and complications, ensuring effective treatment of pneumonia, and providing a stable environment to reduce agitation, anxiety, and risk of harm to himself or others. Summary, a 72-year-old male diagnosed with delirium due to pneumonia and hospitalization, presents with confusion, hallucination, agitation, and disturbed sleep. Treatment includes antibiotics, IV fluids, and potentially antipsychotics. Main concerns are managing delirium, stabilizing pneumonia, and ensuring a safe environment to minimize agitation and cognitive decline risks. Discussion points. What are the potential risks of using antipsychotics in managing his severe agitation? How does the presence of comorbidities like hypertension and diabetes impact the management of delirium? What non-pharmacological interventions can be effective in reducing his agitation and promoting sleep? How can healthcare providers differentiate between delirium and dementia in older adults? What role does early recognition and intervention play in improving his prognosis and recovery from delirium? Thank you, ma'am.
Presentation, and your questions are also all a good questions. Okay, discussion points.
Ma'am, I want to share one more experience happened with me.
Yeah.
That was in ICU. It is your presentation was very nice, ma'am. Today, whatever you told, it all happened when I was working in CCU. One case, he was an old 74-year-old male. He was admitted in cardiac cath lab for the intervention. During the time, he had a cardiac arrest in the cardiac table itself. We revived and we shifted to the ICU. He was there for intubated and we recovered him. He was there for more than 7 days. After the recovery period, we shifted to again to the cardiac intensive care unit. There I was on night duty. I take over the case. He was like that only. He was talkative and all, but he was near to me, where my duty station near. So every day night around 3 a.m. he used to get up. He just come to me. He says, "Ma'am, I want to eat something." So I used to give fruits, biscuits, whatever. Otherwise, we have a routine that 10 o'clock we used to meet. This was happened daily. 3 o'clock he used to having that habit of having biscuits or fruit something. One day I told him, today you will not have anything because I have to take a fasting sample. This next patient was PTCM, percutaneous transluminal angioplasty was done for another patient. So I was giving the report to my senior. That time he was having biscuits. The next patient told, like he said, "Baba, don't have anything." Ma'am said, she has to take fasting sample. I don't know what was the conversation happened between these two people. Suddenly he was having knife in his hand. He just stabbed that next patient. So he was shouting. I called, "Baba, what is happening? Why you are doing like this?" Again, he came with the same knife in back of me. I ran away from the CCU. I called from the other ICU people for helping. Then we stabilized this patient. I informed to the HOD. We evacuated all the patients. Then we after evacuating remaining patients, we put him in a separate room, glass door only. With the grey bandage, we secured him with the legs and hands.
Okay.
After half an hour, we were managing this patient, PTCA patient. He himself hanged that in the curtain rods, this patient. So we didn't know what was happening with the patient, why he's doing. So finally, after these inquiries have all happened, then they diagnosed he is in a hyperactive delirium state. Thank you for giving this opportunity, ma'am. That was the first case I saw. Delirium means what, why it was happened. It was a very bad experience with me.
This is, thank you for sharing, Kumari. This is a seriousness of delirium, right? Yeah. Thank you for sharing.
Ma'am.
Mm. That was a very bad experience, I think. So everybody, I think this is why we should know about like we have to pick it very early.
Otherwise, he was very normal, ma'am. He
Yeah.
used to very normal. Every day he used to eat 3 o'clock, 4 o'clock. We never mind. Okay, he is hungry. That's why he is eating, and he never sleep during night time. So after that, only we come to know he is having the severe delirium state.
Okay, there are so many cases reported, like you shared, no? So many cases reported. Sometimes, like this, a patient who is very normal, very acting very normal, suddenly they become like triggered, and they there was a case in I forgot which country it was. Some patient who was already like he shot like with a gun, and later he was diagnosed that he was having a kind of delirium. That is which is very rare type. He's a young man, and it was not because of this disease also. So everyone, you have to like this is the importance of knowing delirium in ICU. I think every ICU staff should be taught about this. Even in the first in the beginning itself, you have to pick up this kind of restlessness. If they're showing some kind of behavior, you have to this thing. This is the worst thing happened. Many more. Even in our IP setting, we have come across a lot of problems with delirium because these they'll not be in their conscious level, not be very conscious. They'll not be doing what they're doing, like knowing what they're doing. We also had a few very bad experience for our nurses where the patient like give a big hit. She fell down. Okay, so then we had to manage him. He was a very built. Okay, he's a fisherman. It was very strong and built. We could like two, three of. I was on night duty that day, so we couldn't hold him. Okay, so the thing is, you should
Yes.
pick it very early. Try to correct it like as soon as possible. So coming to the discussion points, your all your discussion points are good. Okay. So the first one is what are the potential risk of using antipsychotics? So let me ask you all a question. What are the side effects of antipsychotics? What are the problems? What is the problem of using antipsychotic, excessive antipsychotic? What will it?
Extrapyramidal symptoms will
Very
be
good.
there.
Yeah, excessive pyramidal symptoms. But the
Tremors,
thing is, yeah, very good.
tremors.
Yeah.
Sometimes the patient get confusion, ma'am.
Yeah, correct.
Yes.
Extrapyramidal antipsychotics. Problem with antipsychotics is extrapyramidal symptom. But we have already said that we can use up to a level of 15 to 20 milligrams. So it is very uncommon in this dose the patient can develop all these kind of extrapyramidal symptoms. That's why we give a cut down. We don't we have given so far we have not seen like in this dosage we have not seen extrapyramidal symptoms causing for the patient. So you can safely use up to 15 to 20 milligrams. Very rarely only we go up to this 15 milligrams. If you give a 1.5 itself, most of the patient will improve. Okay, so you can use antipsychotics. Just keep this in mind that overdose, like more than 15 or 20 can cause extrapyramidal syndrome. That too also patient can, the patient will have restlessness, agitation and all. Okay. Now, how does the presence of second point is how does the presence of comorbidities like hypertension and diabetes impact on the manage of delirium? So most of the time, uh, this don't have a direct relation with the delirium, but most of the time it will be elderly patients. Most of the time their immunity will be low. Those patients having diabetes or hypertension, their health condition will not be good. Okay. Okay, their health condition will be bad. So we have already discussed that most of the time, all these kinds of elderly people, more than 70 or more than 80, they are very prone. And most of them will be having this type of comorbidities. So they can in turn precipitate, like they are more prone to develop delirium. Okay. The third point, what non-pharmacological intervention can be effective in reducing his agitation and promoting sleep? Can you tell me few, not, we have already discussed, I'm not going to talk about it again. Can you tell few points which have struck your brain fast? Can you remember few points? What are the non-pharmacological interventions? Few things. It's very common.
Some
Sleep
recreational
pattern.
therapies like
Yeah, sorry?
some recreational therapies.
Yeah, okay. In the
Sometimes,
daytime. Yeah, in the
yeah.
daytime. Okay, good.
Sleep pattern of the patient.
Yeah, very good. Okay, sleep pattern. Concentrate more that the patient sleep at night and wakes up in the morning. Daytime, during they don't sleep. Okay, next.
Ma'am,
Anything?
if the patient is very restless or agitated, so it is recommended that not to restrain that patient.
Sorry? Yeah. You should not read unless they are like very this thing
Violent, yes.
very violent. Try not to this restrain them because that will in turn increase the agitation. You can keep something on the wall that I have told. It's very practical. What is that?
Then, ma'am, padded things can be padded walls can be used to reduce his agitation.
What is that? Sorry?
Padded walls,
Balls. Okay, that's
padded walls.
okay.
Walls,
Balls.
not too hot.
Okay, I'm
Padded
hearing
walls.
I'm hearing it. That's a new
Railings or
thing.
something.
Okay, next thing you can keep padded walls. Okay. Padded walls that will like help them from any hurts. Is that? Did you mean like that?
If any fall or anything is accidentally, they cannot get hurt or anything.
Okay, fine.
Because
Okay,
of that,
good.
padded walls. It's
Okay, fine. Then you can
Hydrate the patient.
hydrate the
hydration.
patient. Yes, very important.
Taking care of their bowel and bladder.
Yeah, okay, very good. You can keep a clock. That is very important. You can
Yes, that
today
is
you can
also.
talk to your nursing superintendent or something. If you don't have a clock in the ward, you can keep that. In an ICU, if you don't have a clock, you can suggest the so and so is there. There is a possibility. Sometimes they will not allow. Okay. Sometimes they'll allow you. It is very in at least in a palliative setting. It's very good to use clocks so that the patient can see. Okay, I'll show that non-pharmacological thing once more. Sangeet, can you just like go back because that is the important thing.
Okay, ma'am.
To the previous slide, just to recollect. No. My slide. No, the case.
Okay, ma'am.
Just a few seconds. I've already the two more discussion points were there. Like we already told, how can we differentiate delirium? Most of the time, it will be in the elderly for a very long period, and for this one, it cannot be. This is acute. Okay, delirium is an acute setting, the non-pharmacological ones. I think down. Go down. Nearing the end.
Just a minute.
Okay. So,
Thank you so much.
and your last discussion point where how can we intervene? intervene in the beginning. Not do not like what wait till something to happen. Okay, what we give, we can pick it up. The patient will show some kind of signs. You have to catch from that. Start your treatment. Try all the pharmacological methods initially itself. Okay, so sleep, see the non-pharmacological optimized sleep-wake pattern, patient orientation, like that is also very important. Okay, calmly orient the patient. Don't tell like you're saying wrong. That is very important. Okay, we see very commonly they get irritated when you tell like oh, what you're saying that is wrong means they get more irritated. Okay, then communication with the family, encourage mobility, monitor hydration, nutrition, monitor bowel and bladder function, provide support and education. Okay. Okay. You have any doubts? Thank you, Sangeet. Okay. Thank you. You have any doubts? Do you have any other stories to share like Kumari had shared? Uh, Very sad story. Any, it is very common, right? You might not have identified it. That's the
Ma'am,
thing.
I have a query.
Yeah.
Yeah, ma'am, those addicted with alcoholics and drugs when they go into delirium, how do we manage?
That we have to manage with antipsychotic itself. But what in alcohol, what we give for alcohol withdrawal, we give certain drugs. We should not solely like rely on the antipsychotics. That is a different scenario. Okay, the treatment is different. We give vitamin, the thiamine and all thiamine injection and all that is different. Okay, I told that this can precipitate as a delirium, but the management is little different. Not like with the antipsychotics alone. We can give haloperidol. We can manage, but there are some other drugs also included, like injection thiamine and all. Okay.
Okay, yeah. Thank you. Thank you.
Okay.
Thank you so much.
Okay. Any doubts?
Ma'am,
You
yes,
have any
ma'am,
stories?
actually we're giving the antipsychotic medicine for the adult, so increasing the dose very fast. But the geriatric person who can't give for the immediate dose increase. Immediately you can't increase the dose. So can do slowly 1.5 mg, 0.5 mg,
Yeah.
or especially the dementia patient in delirium.
So your question is like, can we? Are you asking whether we can increase the dose? Is it like that?
No, ma'am, we're increasing the dose for antipsychotic medicine, especially in the adult, we're increasing the dose very fastly. But geriatric person, we can't do no. So that.
Yeah, we slowly increase the dose. Okay. We only slowly, we see a change for some time. If the patient is very aggressive, we have to manage it. Otherwise, we can give up to 1 or 2 weeks. We can continue haloperidol and all for 1 to 2 weeks and all. Slowly, we have to increase it. We can try to add for some patients. For example, if a patient who is elderly patient and they are precipitating with delirium, we can give tablet haloperidol for a period of few weeks. And once the agitation comes down and the patient's family is telling, oh, see, he's not sleeping. Okay, so haloperidol have a sedation effect, right? So they are telling like there is no sleep. There is no need to increase the dose of haloperidol. We can add a benzodiazepine. We can give a clonazepam. So we are not increasing the dose of haloperidol. We are just using a support or adjuvant, clonazepam. So thereby we try to adjust. Okay, the patient is not getting good sleep. It's not like jump into increase the dose and do. You can give other supporting adjuvants also like benzodiazepine. It's not, but don't give this benzodiazepine alone. You have to give antipsychotic also. Okay.
Thank you.
Okay. So we'll wind up. Shall we wind up the session? You have any doubts? You can clear it.
Very good presentation. Congratulations, ma'am.
Oh,
Very
thank
nice.
you. Thank you so much. Hope you all have understood it.
Yes, ma'am. Yes.
Okay, thank you.
Thank you, ma'am, for the
Thank
wonderful
you.
presentation.
Thank you
Thank
so
you,
much.
Kumari, for presenting the case. Thank you all for participating actively in this session. Thank you. Let's see in the next session.
Okay. Thank you.
Bye.
Have a good day. Bye.
Thank you.